Afternoon, everybody. Thank you for joining us in great numbers. Welcome. This is our first November main seminar. We'll have another one in a couple of weeks. And today we are lucky to welcome one of our colleagues who is based here at McGill University in the McGill University Health Center, and his name is James Tsui. Dr. James Tsui is a radiation oncologist. Many of you are already familiar with him. Some of you are already collaborating with him. I hear some of his students and other group members are here. He's an assistant professor in clinical oncology at McGill. He's the director of the Radiation Oncology Clinical Trials Unit. This is a recent addition, I think, to his portfolio. He's also an FRQS scholar. As a clinician scientist, he's an associate member of graduate programs in biomedical engineering, McGill Medical Physics Unit, and the Surgical and Interventional Sciences. So he actually has a background in electrical engineering. So first trained as an engineer. Then he went on to train as a computational neuroscientist. So he spent some time at the MNI. We didn't overlap at the MNI. I think we kind of just missed each other by a year or so, maybe. And then he went to medical school after finishing his PhD. So he's holds many degrees. What I might be tempted to describe as a Renaissance man, but I'll keep it simple enough. And to finalize his training, he went on to train in radiation oncology and to complete a fellowship in the United States at Brigham and Women's Hospital. Once he was done with that, he hadn't had enough, so he figured he'd do a master's in machine learning, and so that really rounds out a very complete picture of expertise. And today he gets to talk to us about his work in this area. I'm told he's also going to bring in some instructional material. James is an expert in oncology and in machine learning, and he really bridges the gap between the two. So his research interests are going to be the focus of today's talk. And yeah, without further ado.
Thank you for the kind introduction. So today's talk is going to be mostly in deep learning-based auto-segmentation for OARs and CSI, cranial spinal irradiation of pediatric patients. It was a project that was wrapped up maybe a few years ago now, but I felt that it was a very nice, like beginning to end kind of projects that I would like to show for the students. Basically, it's the students engaging in machine learning to see the pipeline and everything that's involved around building the entire thing from A to Z. So maybe I should give you a little bit of a intro on how the whole thing started. So basically, it was a discussion between the Children Oncology Group. So COG is basically a large collaborative international groups who run multi-center phase 3 clinical trials. And they receive all the radiation plan from every participating radiation therapies, radiation oncology centers, and they have to run quality assurance on it. Now, to do it manually is very time consuming. So they were wondering if there's any way of automating the whole process. At that time, I'm talking about maybe 7-8 years ago now. Deep learning or auto-segmentation was not at point, if you will. So they were talking to medical physics unit group here. So basically mostly with Maria and Sharon on whether or not there's any ways of collaborating together so that we could bring the project together, because the COG mostly run at the St. Jude's Hospital has a lot of data, but they were lacking a lot of the machine learning expertise. That was also around the time that I started. I started as a staff, but then I took a sabbatical to do my master at Mila, and the master at Mila required that you do a 6 months internship. So it was just the opportune time basically to get onto this project because it was just sitting there. So it was many birds with one stone. You guys, I think most of you are medical physics, so I don't need to go through what radiation therapy is, but in a nutshell, you have different ways of treating cancer: surgery, chemotherapy, radiation therapy. Radiation uses, ionizing radiation to target your tumor cells. And it's very focused, it creates DNA damage. I'm going to skip all that. And I'm going to skip this too. Basically, the radiation therapy is a long process that's sequential. There's a lot of downtime, but there are a lot of opportunity to automate a lot of the things, and which one of which is going to be the contouring part, which I'm going to discuss in detail today. So what is cranial spinal irradiation? Now, cranial spinal irradiation is a treatment that you give mostly for CNS cancers, but the problem with CNS cancer is that they have a tendency to metastasize, some of them at least, the medulloblastoma, primitive neuroectodermal tumors. They have a tendency of metastasizing through the CSF channel, the cerebral spinal fluid channel. So anything that the CSF touches essentially becomes at risk of disease spreading. So in order to reduce the risk of having metastatic disease or disease spreading elsewhere, we give radiation therapy to the entire CSF, to the entire central nervous system. The challenge is that on children, usually these disease affects kids. There's a lot of organs at risk all around the body that you want to avoid. And to be able to avoid that, you need to be able to know where they're located. And to be able to know where they're located, you need to delineate them and contour them. Now, the difficulty is that on a whole body CT scan, you have anywhere from 400 to 700 slices. The slice thickness is 1.5 millimeters. So to cover the entire body, there's a lot of scans. To do the delineation organ by organ manually, it's long. It's open to inter and intra-observer variability. There are things that you have to consider for the kids. Kids are a lot more radiosensitive, meaning that they're a lot more sensitive to radiation, ionizing radiation, and you could cause some deleterious side effect to the kid. One point in particular, for example, is the vertebral body. You are all adult, your vertebral body has stopped growing. On a child, they are still growing. Now, if you don't irradiate them homogeneously, for example, you can basically knock out the stem cells in certain areas, and then you can induce kyphosis or scoliosis to the children. So the vertebral body needs to be contoured diligently and properly. There's a lot of deviation from protocol when we treat patient if we are not careful. So that is the job of COG, Children Oncology Group, when they receive this radiation plan to make sure that everything is at par and standard. And when they do the quality assurance, slice by slice reviewing is just simply too tough, too hard, and not very feasible. So they're wondering if there's any segmentation tools that were out there. At that point, there were. At that point, there was the atlas-based segmentation, which I'm going to describe to you in a bit. And then there are other solutions that are popping up the scene. So what are the different segmentation methodology? You could do manual segmentation, you can do atlas-based, or then you could do deep learning. And deep learning, you could go for commercial or you could build it in-house. So atlas-based segmentation was that technology at that time. Essentially, you have a bank of data, atlas images, with reference segmentation that was done manually. And then you put your input image. Let's say this is an example of a heart that you want to contour. And you look at what are the images that are most likely resembling this one. You find one, you do what we call a deformable registration to try to deform the heart so that it looks like the heart of your target. And then you do the same transformation on the mask to try to get the target segmentation mask. When it works well, it works really well. Unfortunately, when it doesn't, it fails catastrophically. So these are examples where kidneys are drawn using the atlas-based segmentation tool. You can see that it completely misses the kidney. These are the cases where you're trying to draw the vertebral bodies. You can see that it's actually very poorly drawn. And this is an example of axial slices completely missing the mark. So we go on to deep learning. Now, deep learning, there's a very famous tool that was proposed back in 2015 called a UNet. Basically, you hooked up an encoder that accepts input image. You get the latent representation and you put it back into a decoder so that it can spit you out or segmentation of your images. So this is old. I think that by now it's probably cited like 150,000 times now. So this was first proposed by Ronenberger. It won the ISBI Cell Tracking Challenge in 2015. Since then, pretty much all of the auto-segmentation tool that exists out there in the market is a variant of some sort of UNet. There are some exception here or there, but by far and large, they all use unit. So this is a unit. I put it here for people who are not necessarily machine learning, but I want to go through it. So what does the unit do? The unit takes in an input image and goes through a series of convolutional neural network. And when it goes through it, it extracts salient features from the images. At the early stage, usually it's like shapes of edges and rods and blobs that looks like this. And interestingly enough, if you actually record primary visual cortex from the monkey's brain, you would notice that the kernel of these primary visual cortex neuron actually looks very similar to the automatically extracted features from convolutional neural network. Now, these features are then extracted into deeper and deeper layer, getting more and more complex representation of the images. Eventually, you'll hit the bottleneck where this essentially is your digital signature, if you will, a latent data representation of your input image. The whole thing is then, this is the same thing, sorry, just gonna go over it. The whole thing is then input into the decoder, where the information in the latent space is then extracted again to generate images. And the output segmentation map is basically done by the decoder through the input of the latent representation. The reason why it's called UNet is because it has a U shape, but it's also because it has a U shape because of these skip connections. These skip connections allows for contextual information to be passed through so that you could keep the spatial information at higher level. But more importantly, it solves a very specific mathematical problem. To be able to get the weights, the optimal weights of this architecture, you go through a operation called a gradient descent. Basically, you're differentiating the entire network. Now, the longer the network becomes, the easier your gradient becomes zero. We call it the vanishing gradient. And to avoid this problem, the skip connection allows for signal to pass through so that your differentiation, your gradient doesn't fall to zero and collapse the entire network. So that's the unit. So when I was given this task, I was thinking of ways of implementing this to solve this task. And I was exploring various different methodology. Limbus AI at that time was a commercial product that we just purchased. Limbus AI was built with adult population. So we didn't know whether or not it will work with pediatric population. NNUNet just came out. That was a unit, but is readily downloadable. You could just plug and play. The entire thing is built into a pipeline that obviates all of the pre-processing as well as the data distribution and also all the hyperparameters were optimized based on the signature of the input image. And then I was exploring different ways of actually ameliorating the unit. And I'll explain to you a little bit more what the YOLO stands for. YOLO stands for you only look once, but I will explain to you why I use that. So I implemented a couple of different variants of auto-segmentation. So again, Limbus AI was a commercial path. It costs money. Like, thankfully, we have it. It's fully automated. At that time, we were using V1.6. I think now we're up to, maybe Gabriella can tell me, like, are we V1.8 or no? Yeah, so it's a lot better now, but there were a lot of kinks and difficulty. It wasn't seamless integration. The beauty is that there was no training, just plug and play. But it required a lot of adjustment to be able to use it. So it's no training. That was the cons, because there's quite a lot of organs that we can contour. Vertebral body, for example, Limbus AI doesn't care for it because it was only built for adult, and adult, you don't really care about like the bone as a structure. So some structures were not included in the package. NN unit is something that you can easily download. It was first proposed by Residency in 2018, and then 2020, basically he put his model to the test, and he competed in all of the open challenge that existed at that time. And red dot is their performance in terms of dice similarity, so how close they are to the reference contour. And the beauty is there was absolutely no pre-processing required. It was just a plug and play thing. And that paper really showed that it blew all of the other competition out of the water. And a lot of the people who now work in auto-segmentation simply download the NN unit as their baseline to test their auto-segmentation pipeline to see if it works. NN unit stands for no new unit. So the pros is it's really out of the box. At that point, you couldn't use window. Now it's actually window compatible. There's a lot of things that runs way smoother, but it still requires a lot of GPU. At the time, to train my small data set of 115 patient, it uses by default the fivefold cross validation 1000 epochs, meaning they train every single patient 5,000 times. It took a whole week to train. I was using Compute Can, which now called the Digital Alliance now. Inference for 29 patient requires 65 gig of CPU. It's the equivalent of like 65 movies, 100 Netflix movies. All of it held into the RAM. It took 71 minutes to put the inference of 29 patients. Compute Can at that time, you could actually compute like how much CO2 you were consuming based on the power. And I had fun just looking at like how many trees I was chopping down. So for inferring 29 patients, it was the equivalent of 0.14 gram of CO2, which was the equivalent of driving an electric vehicle for 1.85 kilometers. I was actually very surprised at just looking at that. So I explored my own technique. I built my own models. So at the time, I scoured the literature to see what was out there. And there was something that really bothered me when I was training the patients, because I was feeding the entire body CT scan to get the drawing of like, the optic nerves or the kidney. Like, why would I want to put in the entire body just to get the kidney? So when I teach my residents on how to do my contouring, like I would never tell them to look at the brain if I want them to contour the kidney, right? Like I would give them an abdominal scan. So it dawned on me that maybe the way to do it for auto-segmentation is to guide the model to actually find the area of interest that you want. And doing so, you can cut down on the amount of data that you feed into a model that has no care for like your brain, for example. So there's this thing called instant detection at that time. There are several models that use instant detection. One of which was actually very popular is this model called You Only Look Once. By now, I think we're up to like version 12 or version 15, but the idea was that it leverages convolutional neural network to do instant detection to find boundary box of what you train the model to look at. And it has a lot of application in video surveillance, seeing like where a human is located and following the human, for example, or in security, detecting like whether or not you have a knife or a gun or something like that. So I figured maybe I should just recycle this thing and to detect like where the organs are located for my specific purpose. The NN unit also does something like that, similar, where they guide the model to look at the organs of interest. The only problem with the NN unit is that it uses 3D unit and it passes through the entire image at lower resolution, albeit at lower resolution, to find the organ location, and then blows it back up to a native resolution to draw the target. It still doesn't solve the problem of like putting so much data into locating the organ. So in medical physics, do you guys know what the digitally reconstructed radiograph is? Okay. Do you know where it comes from actually? So back in the days, I'm talking about radiation therapy like 30, 40, 50 years ago, which predates all of us. You maybe not. So it used to be that when we treat patient, we would have X-rays and we would put it on light. And then Dr. Shinuda, he was explaining to me at how he used to do QA at that point. He said I would grab the X-ray, I would take my pen and then I will draw approximately where I think the tumor is located. Now you can imagine that if it's a head and neck tumor, it's the entire head and neck. Nonetheless, if it's a kidney, he would kind of like, squint his eyes and say, I think the kidney is here. And then he would go to the machine and then he would start placing blocks. Like at that point, you don't have the MLC, so you actually have to make the lead block. And then he would place it on the machine and then he would treat it. Now, over time, we have image-guided radiation therapy. CT scan came to the picture. And CT scan, what it does is that when you think about it, it takes X-rays 360 around the patient. And then using the X-ray 360 around the patient, they reconstruct a three-dimensional volume. And each pixel in your CT scan is depicted by the Hounsfield unit, which has a very clear physical property of the universe, which is the density of that material at that specific location, right? So digital reconstructed radiograph came because we reminisce our time of X-ray treatment. So what it does is that it takes your 3D CT and it sums it through the entire like orthogonal plane. So it could be a sagittal scan, it could be a coronal, it could be an axial, basically just sums it. And when you sum the entire target, you have an X-ray projection based on your CT scan. So this is a CT image, and this is a digitally reconstructed radiograph. It looks like an X-ray. And you could play around with the windows to get, for example, just an X-ray that is more sensitive to bone or sensitive to soft tissue. So I took that idea and I started building X-rays images, and then I used YOLO to figure out where the organs of interest were located. And then from these boundary windows, I started extracting smaller 3D CT scans only of the organ location that I was interested in. So for example, a kidney, I was able to figure out that the boundary box is right there. I give a little bit of margin so that I can only get the CT scans of kidney. So instead of like being 600 slices that I send into my auto-segmentation tool, now I'm sending only like, 30 or 40 slices. So it made training a lot faster, a lot easier. And then I started playing around also with the normalization window. Now, when you segment the entire body, you need the entire range of Hounsfield unit. But if you're only segmenting like kidney, which is located in soft tissue, or the vertebral body, which is a bone structure, you don't need the entire range. So I started exploring what would be the ideal Hounsfield unit window as a pre-processing step to send to my NN unit so that my auto-segmentation is much more performant so that I can see like the structure much better. So the pros of having a YOLO and a UNet is that it gives me a lot more control, a lot less memory. I don't need a high CPU. Yeah. Where?
Sorry, about the vertebral body.
Yeah.
Are you trying to contour each one individually?
Yeah.
They kind of all look the same. So how would you use this method to?
I was contouring every single one of them individually, but also the intervertebral spaces as well. And as long as your target, your reference has all of that, you could train the model to recognize what are the, where it is located.
Right. So you give it a DRR.
No, the DRR is just for instant detection of figuring out where the boundary box are located.
Right.
It will be clear after. But once the boundary box are found, then I extract like the CT images from within the boundary boxes only. And that's what I give the auto-segmentation tool.
So for the vertebral body with the bounding box, all the
Yeah.
that look the same.
Yeah.
That looks similar.
Yeah, the entire thing. More control, less training, less memory. Con is it's easy to lose control if you don't know what you're doing. It's really easy to undertrain, overtrain. It requires a little bit of domain expertise. You need to know your deep learning. Yeah. So, and then I was exploring different kind of units. So there's in 2016, Attention is All You Need, that famous paper that actually was this the turning point of large language model, showed that if you build attention mechanism into your deep learning model, you get a lot more information, not just local information, but like also information across the entire input space. So somebody actually did that and implemented attention module into a unit in 2018, and it showed that it helped with the auto-segmentation. So I decided to look at that too. And then I'm just gonna skip that. And then there's the idea of 2.5D unit. So when I contour a kidney, for example, I don't ever just look at one axial slice and I just do my job there. I actually look at a few slices above and a few slices below, because that gives me a lot of contextual information. If few slices above and few slices below, like this structure that I thought was kidney is gone, then I know that that was actually probably a bowel and not kidney. But if I keep going up and down and I see like the beautiful bean shape, then that's where I know that the kidney is located. So the idea of contextual information can be injected into your model by just expanding the channel. Instead of just giving one channel at a time, you could give like a channel above, a slice above, and a slice below, and use this unit to actually look at the contextual information. So that's what I also explore. It's not a lot more work, but the training become very unstable. Especially if you push it. The blue line is the training, the orange is the validation curve. And the reason why I think is because some of the slices above the brain, for example, is just like an empty slice because there's nothing else above it. So when I give it to the model, it kind of created a lot of instability during training. Things that I could easily curtail, but I just didn't have time anymore at that point to fix a model. So the entire pipeline looks like that. First, patients are identified. The data was split into training validation. Training validation came from St. Jude. Testing data set came from McGill. All of these patients had their contours manually done. They're all anonymized, and then they were exported into a Python environment. Now, for reference, I was using Limbus AI. Limbus did not need to do all these stuff because you just input it into Limbus and it'll spit you the contour. Within the Python environment, there's the pre-processing that has to be done. YOLO was something that was added afterwards, so I have to generate my own label, and I generated the boundary box based on the reference target that I have to figure out where the boundary boxes are. That's how I got my label extraction. For my model, I have to go through YOLO to figure out the object instant detection where the organs were located before I put it into my segmentation tool. For the NN unit, it doesn't use YOLO. So after the pre-processing, I just inject it directly into it. After my segmentation, I need to do some post-processing, after which the metric that I use to measure whether or not the organs were well drawn is based on two things. Originally, it was based only on dice similarity, which is an overlap of the reference and the drawn contour, how much it overlaps, the volume it overlaps. That is actually the loss function. But when we submit it for publication, the reviewer rightly asked, well, who cares if it's actually like a good dice or bad dice? I want to know whether or not the clinician actually likes it. So the other metric that we used was actually clinician judgment, whether or not we can actually accept the contours. So the pre-processing. So in all, I had like 168 patients from St. Jude. All of the images and struct file were in DCM DICOM format. Rename all of the labels because they're all named like differently. So I have to rename them all the same, convert them into Nifty. And then I looked at the distribution of the resolution, the slice thickness. Thankfully, they were all the same resolution, 1 millimeter per pixel. All of their slices were 1.5 millimeter per slice. So I didn't have to do any normalization or anything. They were already done for me. Like I said, relabeled all the mask, and I eliminated some exception. Testing data set came from McGill. It says 14 here, but I actually had like 16 or 18 afterward. McGill data set was a little bit more all over the place. Resolution was bad. There was a big variation. So was the slice thickness. So I remember I trained only on a training data set that has a very specific resolution size and slice thickness. So I had to make sure that my testing data set matches what I was trained on. So I had to do a lot of linear interpolation on that. There are things that I couldn't fix. For example, the way we draw the vertebral body in St. Jude, we only draw the vertebral body, but at McGill, we draw the entire thing, including the lamina, the spinous process, and the transverse process. So unfortunately, as you can imagine, the score is going to be really low in terms of the dissimilarity. So in the St. Jude data set, these are just example of patients that I had to knock out. This one is because of severe scoliosis. So I took out 10. And there's some kid that actually look more like an adult, so I had to take them away too. These are all the organs at risk that I had to rename and use as my references. So that's just a pre-processing step. Oh, and I set everything outside the body to minus 1000 Hounsfield unit, which is essentially air, to help my model, because I didn't think that adding like the couch or anything like that would help the model. Okay. Label extraction. So I had to extract the boundary box. So what I did is I looked at all of the organs and I looked at the maximal extent of their lateral and superior inferior, as well as the anterior posterior. Based on those pixels, I got the reference boundary box, and this is what I used to train my YOLO. So the first thing that you must do is look at your data set to see if it makes sense. So I started looking at these boundary boxes, and I started looking at the midpoint where they were located. And I figured out that there's quite a lot of deviation. For example, the left lung midpoint boundary box is actually on the right side. Same thing for the cochlea. The brain, instead of being like high up in the body, is somehow located also below. Turns out that when you do, and you, as a medical physicist, you'll see that all the time, when we put a plan to treat, oftentimes, well, not often, but sometimes accidentally we put a pixel somewhere, and that completely screws, you're laughing, that completely screws up your external beam planning. Like these are things that like dosimetrists would actually flag. But like, you know, if you're going to be doing machine learning, you got to be like, have a good handle of your own data set. So it turns out that there's a lot of these noise, reflective of what we see in the clinic often. And then I look at the size distribution. Like a kidney is supposed to be like a certain size. It doesn't make sense that all of a sudden you have a ginormous kidney. So instead of looking like each patient by patient, I looked at the distribution, and I was able to flag like all of these weird stuff. And there was a lot of weird stuff, like in the reference, for example, a kidney that looks like that. So like clearly it was wrong. I don't know how it got through, but basically they actually went to planning like that. So that had to be corrected afterward. But when I got the data set, it wasn't. A cochlea, sorry, that's a cochlea who had an extra pixel somewhere out of the head. So I figured like I cleaned out the entire data set. That alone took a lot of time. When I did the DRR, I was exploring different windowing. So I knew that I wanted something that's good for the lung. I knew that something good for air, something good for soft tissue, something good for bone. So I started exploring different Hounsfield unit. The lung, I clipped it at minus 1,500 to 0, and it was able to give me a DRR that looks like that. Soft tissue, when I clipped it to 0 and 50, give me like something like this that I could really see the kidney well. And then the bone, I only clipped like high Hounsfield unit. And then YOLO accepts 3-channel because it's RGB. Now it was done for natural images, right? RGB. But I figure I already have 3-channel. Why not use it? And it turns out when I put all 3 DRR together, it gives me some scary image that looks like that, but I thought was very useful for me. Like I could really see exactly where the heart is located and the kidney was located. I call it the composite image. And then I trained the YOLO. So this is an example of detecting where the brain is located. This is an example of detecting where the kidney is located. And you were asking the spine. This is an example of the boundary box of the spine. So pretty good. So I started I started extracting these 3D CT scans, and then I noticed something weird. When I started looking at the distribution of my YOLO boundary box, I saw that some of them fell spectacularly. Like some of the YOLO boundary box were way off, like a lot smaller than the reference. And I started looking at these cases. Now, this is the reference boundary box for CTV spine, and this is the YOLO boundary box. And I thought that I'm doing something wrong. It has to. But turns out it was actually the reference that was completely off. So even though I was injecting noisy data to train, the actual inference was actually better than some of the references. And I was actually using that to figure out like what are the cases that had very bad drawing. And then using YOLO, I was able to discover a few more examples where like the reference were poorly drawn. And I gotta say, like, this is a good learning experience for me. I should have looked at every single patient slice by slice for all of them. But I was a lazy student at that time. I did not. But the deep learning model, even though it learned from noisy signal, was able to recognize actually properly how to draw certain organs, which I thought was pretty neat. In the end, I discarded a few more. I split my training and validation data set. I made sure that the distribution of data were the same. And then again, the test data set was the McGill data set. The NN unit didn't have to do a lot of pre-processing, but through the NN unit also, again, discover like a few more that was really bad because NN unit was able to learn the good signal and draw properly. And when I looked at the bad dice score, it turns out the reference was horrible. In terms of the metric, again, I use a dice similarity to see the overlap, and there's no overlap. The score is 0 is perfect overlap. The score is 1. I wanted all of my structures to be 1. After I did my segmentation, there were some false positive that were like, a couple of like pixels located somewhere far. I use 3D 26 neighborhood connected component to just extract one organ at a time. And then I put the entire thing to the test. Now, this is a noisy table. I will show you what was actually published. So in the validation score, the first 3 are my model. The green is Limbus AI. The yellow is NN unit. Immediately, you can see that the Limbus AI doesn't do well for esophagus and CT spine because it's so used to look at adult, and adult has a shorter CT spine, and adult also has a larger caliber esophagus. So a lot of the time, the Limbus AI actually contoured the trachea, thinking that it's esophagus. So overall, my model did as well as the NN unit. That is for the body structure. For the head structure, it did better than the NN unit in a few of these structure. And the lenses is actually not as good, but otherwise this is pretty much on par. And the test data set, same story. Maybe the esophagus is really bad, and NN unit was a little bit better on the test data set. But what was interesting on the test data set is that NN unit does poorly on any brain structures. Again, because it wasn't trained on the same resolution, I had to do some fixes, the interpolation, but also because NN unit uses data augmentation, and one of the data augmentation that it uses is mirroring. So if you start mirroring the head, left eye to the right eye, the reality is like you can't differentiate it no more whether or not you're contouring the left eye or the right eye because it came into the training process. So it keeps flip-flopping between the laterality of the structures in the head. When I look at it visually, this is an example of the CT spine, and then unit does it well. This is a reference. Limbus AI essentially just cuts it, and these are all of my segmentation. This is an example of esophagus reference. And then unit actually didn't do well on the esophagus and misses the left part of the esophagus. Limbus AI just fell completely. These are like the different esophagus contouring. Kidney was this is actually not that bad, but this is an example where the reference was horrible and then unit was able to draw properly. Limbus AI completely misses it, but my model were fine. And if you look at the coronal slice, no, this is the coronal slice. You can see a lot of false negative and some false positive from Limbus AI. And then UNET did a lot of laterality problem in the head structures. Limbus AI is fine because a kid's head structure and an adult head structure is very similar. My model. These are just other examples. Just gonna skip. When I start looking at it a little bit more detail, turns out that the Limbus AI, where it fell for kids who we use a cutoff of 10 years old, but we could have used another cutoff. But the idea is a kid that's under 10 and a kid that's older 10. Older 10, you start looking more like an adult in terms of the anatomy. Under 10, you look like a kid. So it turns out that Limbus AI doesn't do very well with the CT spine for young kids, the kidney and the lung. We hypothesized the kidney is because adult actually has a lot of fat around the kidney, especially the left kidney. Whereas kids, you don't have a lot of fat. You just have your stomach and you have like all of the organs around the intestine. So Limbus AI was trained on adult data set, so it worked poorly. And the test data set, it's more or less the same story except for the esophagus. Esophagus, oftentimes it will contour the trachea of the kid because the trachea of the kid has the same caliber as the esophagus of an adult. And this is just an example of how dice-score similarity is one thing, but you should really look at clinician, how they accept the contours. This is a training data set. Blue is when blue and light blue is when the clinician accepts the contour. Red is when it's completely rejected. You have NN unit Limbus, and then you have like all the three other stuff that I did. So most of the time, like the lung, the brainstem, the brain, the cochlea, the eye structure, the lenses, did it okay. Limbus AI obviously has a lot of red. NN unit didn't do too well with the cochlea and the eye and an optic nerve, which we understand why. And the test data set was pretty much the same story. Anyway, so I wanted to leave some time for discussion, so I'm going to go on with the summary. Now, deep learning auto-segmentation commercial at that time still needed a lot of care and oversight, a lot less now. And I don't know if the new version actually works well with the kids, but last I spoke to the folks at the Limbus AI. By the way, one of the owner of Limbus AI was actually a McGill graduate, also the guy who invented VMAP. Anyway, so he's the CEO told me that he didn't want to venture into the pediatric market. One is because it's small, but the other is because he felt the ethical obligation to not screw up. So that was the talk a few years ago. I don't know if it's the same. In any case, it got bought by Radformation. Out-of-the-box segmentation tool, the NN unit is good if you want to use a nice benchmark. The only problem is it's very heavy. You have to run the entire thing. Certainly, the inference you need the GPU for. Not every center has that capacity to use clinical GPU for research purposes. Custom built, the entire thing actually, the inference was, I could run it on my laptop. So once I built the model, I actually have the model on my laptop and I was watching Netflix and it would work. So it was very light to use, and which made me very happy. So that's pretty much it. Just the capacity. Oh yeah. So the paper is now published. Actually, Alana did a lot of work afterwards. She wrote the paper essentially. I gave her the data, and then this one I'm really happy about. They took my model, and they went back to St. Jude, and then prospectively they validated the model. And they validated against 3 commercial products. One of them is Siemens. The other one is, I forgot what it was. Anyway, there was 2 other, MIM. And turns out my model worked better. So I was really happy because it only took me 6 months to do in my room. So yeah, this is it. There's no future direction. The project's closed.
Thank you, James, for excellent presentation and a nice overview of a complete project as you described, beginning to end. The floor is open for questions. Those who are on Zoom, I'll be monitoring the chat, different types of questions. So we'll start with a question here at Blue Insights.
Thank you very much.
Oh, okay. Repeat the question. Got it.
Well, depends if they're hearing.
Yeah, I was wondering, when you showed like the loss function, and you got like this instability
Yeah.
at the like later efforts. So don't you have these empty brain slices in your training model? Because like I was thinking maybe like convolutional neural network can deal with this kind of things.
Yeah, probably. Okay, so the question is in my instability training for the 2.5 unit, I hypothesized that it was probably because of the empty slices. So the keyword is hypothesize. I don't know. I didn't actually look at it. At that point, I figure, well, it's unstable, but it works, so I'm just gonna keep it like that. So I actually didn't like go back and really dig into it. I mean, it's an interesting question. I actually like I was also like at that point, I was closing the end of my 6 months and I had to come back to work. So I really wanted to explore it, but I had to abandon it. So I didn't look. Yeah. Moving back first.
Next for the next talk, I was just wondering, when you're running inference, is it one trained model per structure, or is it one trained model on the all structure?
Yeah. So you're asking whether or not it's multi-class segmentation versus single class binary. Yeah. So for the NN unit, it's multi-class. So that means that the structure cannot overlap. So I had to do some post-processing to include the brain stem into the brain for the NN unit. For my model, when YOLO, so how it works, the entire pipeline is that I feed the inference to a YOLO pipeline that extracts all of these organs by organs and put it into a new temporary folder. And I have 18 different unit model to do the segmentation for each one of these organs. And then I have a post-processing stage where it combines back the segmentation mask into a whole body. And so, yeah, to answer your question, it's 18 different models. But interestingly enough, it was still able to run on my laptop. Oh, sorry, there was a Sebastian. You actually saw the entire thing built, actually. You were there in all those yeah. Meetings.
First, so you said Einstein is really good with your custom pipeline, but not with NNet. Is it because of the cropping that's with the Euro, or is it because of NNet model actually is more?
It has, well, actually, maybe I should ask Ben that question. You're working on NNUnit a lot now. NNUnit is just a heavy package. And it's heavy because it's designed to contain all possible situation, all segmentation tasks, and it throws in a couple of different models as well. You have the 3D unit, you have the 2D unit, you have the high resolution, you have the low resolution, you have the crop resolution. So it comes with the entire package. My thing, for example, the unit for the kidney, like instead of being 256 by 256 pixels, is actually just 36 by 36 pixels. So it's very light. And if you like the complexity of a model goes exponentially high, right? Like you increase a factor of 2, your complexity increased by a factor of 4. So by doing that, I was able to like really shrink it down. Do you have anything to add, Ben? Or pretty much.
That you're using the cascade, you're inevitably gonna have more complex.
Yeah. Yeah. So any unit uses cascade, mean like it passes through one unit first and then it passes through a second unit. Yeah.
So the models usually not.
All of my models are 2D. Yeah. Because I leverage the DDR, the digital reconstructed radiograph to get 3D boundary box. And I didn't have time, but the next thing I wanted to do was actually, there's certain organs that makes more sense to contour on the coronal and sagittal slice. And what I wanted to do was actually contour on the coronal slice, contour on the sagittal slice, contour on the axial slice, and then do some sort of an ensemble model or just skip the axial altogether and just like do an ensemble model of the octagonal plane. Because the reality is oftentimes where you fell is not in the center of the organ. It's often in the contours. And oftentimes it's the most superior slice and the most inferior slice that you have difficulty drawing, because this is where it gets tricky, right? The signal is lost. But however, if you look at it on the coronal slice, you could really follow the entire contour. So that was my hypothesis. Like my hypothesis was, if I use all of the octagonal slices, where I would get the biggest bang for the buck is in the periphery of the organ in terms of the signal clarity. Again, it's a lack of time. Otherwise, I would have done it.
So you use that's
Yeah.
How does it take and compare it like a knowledge-based strategy where you know the difference in the size of the brain from the
Yeah. So the question is, like, how long does YOLO take, and did I use knowledge base? I was actually thinking about using knowledge base at the beginning because I had the like all of my patients were centered in the body, and all of my patients, like your left organ is always going to be on the left side. And I was thinking whether or not I should use that for YOLO. Sorry, whether or not I should use that. That was actually like baked into YOLO. When I guide YOLO has a tendency of like determining like all of your organs. So for the eye, it would detect both eyes. So I use knowledge base actually to guide YOLO to figure out where exactly the organs are located. And yeah, so that's how I use knowledge base within YOLO. Yeah, just one alone wasn't sufficient. I tried both actually, but just one alone wasn't sufficient. So yeah, I ended up using that. Yeah.
Thanks for this great talk. Yeah, as Dave said, the great overview of the project is not just about the AI training, basically a lot of processing. Good job for all getting it done. You said at the end, there's no future directions. We didn't understand it. What do you mean?
I mean, there's probably future direction, but it's just like I don't have any bandwidth for future direction for this project. Like they have asked, like, did I wanted to commercialize it? But to commercialize it will take a lot of overhead. Like I have to involve St. Jude, and I have to involve McGill, and I have to involve Mila, and then the market is not great. I mean, it's pediatric, right? There's only one place that would actually very much use it, is St. Jude and maybe PMH. And at the end, like, you know, segmentation tool is getting better and better. So I was like, I don't have enough energy for that at this point. That's why I said no future direction, but more no future direction for me. Yeah.
Good. Ask another quick question. You know, something exists just called Bayesian UNet.
Yeah.
I wanted to ask you if you think this could be useful for that type of application, basically in the sense that it doubles the number, basically the number of weights you have to learn, because it learns the weights of the UNet, but also like the standard deviation around these weights.
Yeah.
But in the end, it yields a map like you showed, but a map also of the uncertainty of the contours. Could that be clinically useful? Basically, you look at these two.
I think so. I mean, at the end of the day, you're saying that basically increasing your dissimilarity score, essentially, that's what it would do. Probably. I don't know. I mean, NN unit was tested against like all of these new models that try to do segmentation, including the vis transformer. They usually use NN unit as a benchmark. I find that most of them doesn't change that much. Like your architecture doesn't change the performance, because NN unit is actually pretty awesome, surprisingly. And people have tried different architecture, VNet, HalfNet, UNet. Like when I was reading it, I was very impressed with NN unit, even the transformers. At the end, there was not a lot of huge gain from like different architecture. I think maybe we could try Bayesian. But when I started working on it, I think one of my biggest concern was like applicability and time. And that's why I was trying my own model. Yeah.
But not just necessarily improving the description. I mean, looking clinically like at a map of the contour, but the uncertainty associated with it. Would that be like really extra information that would be useful? Or
probably. I mean, when I was doing this work, I was also exploring other stuff, including, because like one of the stuff that I found was in heart segmentation for the contour of the LED and the coronary vessels. they were good, but they were not great. And when they're not great, you could tell like from far that it's not great. It's not even statistic at this point. It's just visually, it's not appealing. So interestingly, what they did is they built in the variational autoencoder. And based on the output of the mask, they look at whether or not it's a credible structure. And then they use variational autoencoder, which in a sense is kind of a built-in statistical model because it looks at your distribution to give better contours, more credible contours. And I thought that was pretty neat. I actually explored GAN to do segmentation. So like the idea is that my original thought is if you can build a face using GAN, it's a very powerful model. It should be able to just build mask. And so I put all of my mask and I trained my, I don't have it here, but it was really fun to play with. Because GAN takes like a vector, and it could be a noise vector, and then it outputs a shape, right? And it turns out that that vector, each one of these distinct channel encodes a specific feature. And I use a GAN to generate every single possible kidney mask that I had in my data set. And then I started playing around with like the input channel. And some of the input channel was really cool because like a kidney is a bean shape. But like when I start playing around with the one channel, for example, it starts losing the bean shape and then becomes oval. And so my idea was like, wow, if I have such a powerful GAN, maybe what I need is just a powerful encoder to know exactly the type of kidney that I need to be able to output the mask. I did that, but like the result were okay. I didn't really push it because the problem with GAN is that you have a lot of these collapsing mode problem. But I think it was an interesting direction that if you use generative model, because at the end of the day, it's the same thing. Your unit, like look at the latent representation, gives a mask. But if you could do that, I was thinking about using GAN, but again, lack of time, I didn't push it. Yeah.
That's very interesting.
Yeah, that could be a future direction.
Yeah.
Yeah.
Okay, I think we've been through a good amount of questions that I think we addressed the topic really nicely. Thanks again to our speaker today for very interesting and now that wraps up our session, and we'll see each other again in 2 weeks for the next seminar. Thanks again.
Thank you all. Sign.